Next, I would like to request Dr. Kousik Saha. He's a head of Department of Medicine, head of Department of General Medicine, KPC Medical College. His topic for today is PPG Management with reference, with special reference to acarbose. Sir, please. A round of applause, please.
Good morning, and thank you for inviting me for this particular conference. And we have an excellent speaker in Dr. Saha, basically. And the topic is very interesting. It is the postprandial control. We should be aware of the fact that Indians and Southeast Asians, probably at any HbA1c, it is a prandial control which is more important in to bring the HbA1c down. And today the focus would be there because this is where we are lacking. And he is going to take us through the prandial control. And it's all yours. Please go ahead.
Thank you. Good morning, everyone. I think the topic should be after the post-lunch, but unfortunately it is in the early morning because I am talking about the role of AGI, especially watch out the carbohydrates. I think I have changed something. There is a PPG control, special reference to the acarbose, but I will like to broaden up all these things, the role of AGI and where we stand. So my topic will be around these 5 areas. That's first of all, I will discuss about how the Asian Indian patients are different from the Western regions. Second part of my discussion will be the dietary carbohydrate contents, why we are more focusing about the AGI in our clinical medicines as far as the Indian region is concerned. Then the third part of my discussion will be the significance of the postprandial hyperglycemia management, why we are more giving importance to the postprandial hyperglycemia in our clinical practice. Fourth part will be the role of the acarbose in this area, and fifth part, that is the last part, will be what are the robust clinical evidence which we have to start the acarbose in our clinical practice. First of all, I like to say that in every diabetes or endocrine areas, we always discuss about the GLP-1 receptor analog, or we are discussing about the ASIL2, or we are discussing about the DPP4. Today I have got a topic is slightly different, that is called AGI, because we generally do not use AGI frequently in our clinical practice. Why we should use this AGI in our clinical practice, I think I will discuss all these things in next 20 minutes. So what is the current scenario? I think in India, that is the Southeast Asian peoples are slightly different from the Western regions. That means we have got a higher beta cell dysfunction as compared to the Western components, and the marked deficit in the first phase of the insulin. I think you know that the first phase of insulin is only the beta cell dysfunction marker. So here in our country, in our setup, we have got this beta cell dysfunction, and that ultimately leads to the onset of type 2 diabetes in a very young age. You know that the duration of the diabetes is actually having effects over the macrovascular and the microvascular complications. So if we have got the patients who have got the type 2 diabetes in the younger age, I think we have got the complication in the middle age. So we have to take care all these patients in our clinical practice. And impaired glucose tolerance and the postprandial blood sugar levels is the first important thing has to be observed in any type 2 diabetic patients. Here we are calling the lean thin Indians because we don't have so much of obesity in the form of subcutaneous fat. We have got the fat in the visceral area, which is one of the most important determinants of the insulin resistance. That's why we have got the low level of adiponectin and having the more insulin resistance and the hyperinsulinemia. So what is the real culprit in uncontrolled hyperglycemia? I think the high carbohydrate consumptions. I think that's why we should talk about all these things after the post-lunch. But thing is that if you see the carbohydrate contents all over the world, all over the India, I think more or less it is more than 60%, 67 to 67% in different areas. Although we have got the more areas in the middle as well as the south, but still eastern region also consumes more carbohydrates, and that's why if you take more and more carbohydrates, I think we have got the high peak after taking the feed. So glucose variability, which is the most important factor for giving the macrovascular or the microvascular complication, if you have got the more and more peak, that means the glucose variability is there, and that's why we have got a lot of complications in the form of macrovascular and macrovascular complications. And the early phase of insulin deficiency, as I've said in my first or 2 second slide, that is also a determinant of that this glucose variability in our clinical practice. So we have to take care of all this glucose variability, especially for the carbohydrates. So apart from all these drugs, that means we have got the SGLT2 inhibitors, we have got the DPP4 inhibitors, we have got the GLP-1, still we are not able to control this glucose variability because of the high carbohydrate diets. And you can see that if the person, you just see in this area, you can see that if the person is taking less than 60% of carbohydrate, and if he or she is taking more than 60% of carbohydrate, you can see the level of PP blood sugar level rise, but the fasting blood sugar level is more or less normal. So if you do only the fasting blood sugar level in any patients, it is not sufficient, because if or she is taking more and more carbohydrate, I think you can have this postprandial blood sugar level different, and that has been reflected in the HbA1c level. Apart from the high carbohydrate diets, I think it is another important thing is that the glycemic response. For example, we Indians are taking the same things as compared to the Westerns, but still the glycemic response is different. You can see that the lot of biscuits are there, but all you see that the UK peoples have got the less glycemic variability as compared response as compared to the Indians or Caucasians. So that's why it's very important to have that only the carbohydrate content is not the sufficient, it is also the glucose response is also high. So if you take 60 or 70% of the carbohydrate, but still it has got a higher responses as compared to the Western. So Indian subcontinent is different. That's why all the guidelines like ADA guidelines, ESD guidelines they are making the guidelines for the all over the world, but still they are more favoring to the Western peoples. But Indian peoples are slightly different. We are taking more carbohydrate, we are having the more glucose response. So we have to think of different molecules to have for control of glycemic areas as far as the diabetic management is concerned. Another important issue is that HbA1c level. You can see that initial part of the HbA1c, that is 7.1, 7.2, mostly the PP blood sugar is, if the patient having the high PP blood sugar, you can see the components of the HbA1c is high. So initial phase, for example, the patient coming to your clinic with the HbA1c level of 7 to 8, I think you have to concentrate more about the PP blood sugar control rather than the fasting blood sugar control. Because if you are not controlling the postprandial blood sugar level, I think you are not controlling or maintaining the HbA1c level below 7. So that is very important in your clinical practice to assess the postprandial blood sugar level. What happens in my clinical practice, I always see that patient usually give the once blood, that means in the morning. They don't give the blood in the postprandial. They say that, okay, I am doing the HbA1c, I am doing the fasting blood sugar level, why I should do the PP blood sugar level? But here is the importance. If you are not taking care of the PP blood sugar, I think the postprandial blood sugar level is not controlled, then you cannot control the HbA1c level. There are a lot of studies has been done from the 1999 to 2017. I am not going into the details, but the thing is that postprandial blood sugar level is independent risk factor. Why you are talking about the postprandial blood sugar level? Because it is an independent risk factor for the macrovascular complications. So if you are not controlling the postprandial blood sugar level, I think we miss the bus. I think the macrovascular complication will eventually occur after 10 or 15 years down the line. So there are a lot of studies like Framingham offspring studies, STOP NIDDM studies. These are landmark studies. They have documented that if you are not controlling the postprandial blood sugar level, you are not able to control the macrovascular complications. So PPG control reduces the CVD risk factors. They have documented by decreasing the triglyceride levels, decreasing the TG, total cholesterol, LDL-C, increase the HDL-C level, as well as decrease the blood pressure level. And important thing is that show the progression of the control of IMT, carotid IMT, and even the partial reverse. So all the markers which are actually complicated or actually make the patients having a macrovascular complication, that has been reduced if you control the PP blood sugar level alone. So this is very important in your clinical practice. We tend to follow only the fasting blood sugar level and the HbA1c in our clinical practice, but don't forget the importance of PP blood sugar level for the control of blood sugar level. Now coming to the AGI, why I am discussing all about this? I think you know that most common drug, most useful drug for controlling the postprandial blood sugar level is the AGI. And among that AGI, I think acarbose is one of the most important things. Now there are three type of AGIs available. I think we are not using this miglitol nowadays, so that's why only two drugs are used in our clinical practice, that is called the acarbose and the voglibose. So what is the difference? Because I think the voglibose has got more noise value rather than the acarbose. But the thing is that if you see the enzyme inhibitions, I think only the voglibose is having the effects over the disaccharides. But in cases of acarbose, I think they have got the alpha glucosidase, that is alpha amylase, as well as polysaccharides, oligosaccharides. You can see that the chart, I think it also acts over here, also acts over here, and also acts over here. But voglibose does not have any actions over the starch, that is the polysaccharides, as well as over the sucrose. So if you start only giving the voglibose, I think it is inappropriate effects as far as the AGI is concerned, as far as the book teaching is concerned. But I will show in my latest few slides what is the real evidence, because it is a theoretical evidence. We should look for the real world evidence as far as the management is concerned. So 25 years of the acarbose, I think we are using for the more than 25 years. So we have got all the documents, all the effects, all the side effects. We are very much confident that we can use the acarbose in our clinical practice. You can see that without the acarbose, the curve is slightly reversed. That means the carbohydrate absorption is very much up and goes down. So that ultimately produces the peak. And that is why we are more concerned about the glucose variability. But you can see that with the acarbose, that is the green one, it is a flat one. That means the absorption is less. And also it has got the insulin sparing activity. And later on I will say that it also increases the GLP-1 areas as far as the management is concerned. So you can see that with the acarbose, the postprandial blood sugar level is low. With the acarbose, there is a less amount of insulin. So this is quite evident. It is also associated with the low body weight, as well as there is no hypoglycemia episode. It is also clear that it has got a very good, apart from the glycemic control, like body weight reductions, like hypoglycemic episodes. Another important thing is that I think these very important observations. That means it stimulates the GLP-1, because we are giving the DPP-4 inhibitors for the GLP-1. But here also you can see that the stimulation of GLP-1 after 60 minutes is likely to reflect the presence of unabsorbed carbohydrate, which ultimately stimulates the L cells and produces the amount of GLP-1, which is a very good important thing. You can see that head-to-head trial with the allogliptin, that is the DPP-4 inhibitors. You can see that after 45 to 60 minutes this goes down. But if you add acarbose on top of the DPP-4 inhibitors in the form of allogliptin, you can see it can sustain having actions over the GLP-1. So this is very important observation. So it is not only the alpha glucosidase inhibitors, that means prevent the absorption of the carbohydrate, it also stimulate the GLP-1. That is a very important observation. That is a very important thing to have in our clinical things. And also you can see that the Western diet, that means you can, this is a red one, Eastern diet and the Western diet, the HbA1c reduction, I think it is more in the Indian subcontinent rather than the Western areas. So if you start giving the acarbose or the AGIs in your clinical practice, then I think the HbA1c reduction is more as compared to the things which has been documented in the Western studies, that means 0.8, 0.9. In our country it may be 1.5 or 1.8. And it also can be given in the beta cell functions, medium beta cell function, and the poor beta cell function. You can see that there are three areas where we can start giving the acarbose in spite of the insulin, because it is a insulin independent actions. It is also having effectiveness in the lowering of the alpha glucosidase inhibitors in the form of HbA1c. And one important thing is that you can start as giving as a primary prevention has been, that means the patient is pre-diabetic. In the pre-diabetic status, we generally start with the metformin. But here you can start with acarbose. You can see that 25% reduction in the incidence of development of type 2 diabetes starting the acarbose, increase in the reservoir to normal the glucose tolerance more than 35%. So acarbose has got effects of the pre-diabetic. So whenever the patient comes to your clinic with a pre-diabetic, you can start with acarbose along with the metformin. So you can see that if you start acarbose with metformin, this is the very right combinations. Generally, we prefer to add the acarbose with the metformin. You can see the acarbose is taking care of the PPG, metformin is taking care of the fasting blood sugar level. And you can have both this acarbose and metformin associated with the increase in the GLP-1, and there is no history of any risk of weight gain, risk of hypoglycemia is minimum, and the cardiovascular benefit is there. So it is very good right combination to start the acarbose in metformin, taking care of both the fasting blood sugar level as well as the PP blood sugar level. There are a lot of studies, I am not going into the details, but you can see that a lot of studies has been done to document the presence of acarbose in our clinical practice, like HbA1c reduction in the GLOBE studies. You can have all these things. But which AGI should we choose? Whether we choose the acarbose or the voglibose. So what should be the head-to-head trial? I think these are the two head-to-head trial where you can compare between the voglibose plus metformin and acarbose plus metformin. You can see that in the acarbose plus metformin arm, there is a more reduction of the HbA1c, more reduction of the fasting blood sugar level, more reduction of the 2 hours fasting blood sugar level, and body weight reduction is more. So that's why in our clinical practice, if you choose to start any AGI, I think acarbose will be the number one as far as you is concerned, as far as me is concerned. So that's why ESI, RSSDI, the local body, has always recommended that AGI should be recommended in almost every individual approach patients for the Indian, because we are taking more carbohydrates. IDF is also including these. Japanese areas is also including this. China also includes the AGI as a number one anti-diabetic agent. So don't forget the importance of AGI. That is my topic in my today's things. So up to that, I think we have discussed all about the level of acarbose because of the glycemic control and all these things. What should be the beyond diabetic control? Because you know nowadays any drug which does not care about the CV benefits, does not care about the obesity, I think long run this drug will not have any effects, because only the glucose lowering effects is not the ideal one. So what about the glycemic variability reduction? What about the CV benefits? What about the body weight reduction? What about the important things like the gut microbiota? So these four things are to be seen as far as the acarbose is concerned. So first we look at the glycemic variability. As I have said in my first or two slides, that the PP blood sugar control is one of the prime importance for controlling the glycemic variability, because if you are not taking care of the peak, then it is very unfortunate to see that glycemic variability will be lost. So that's why the acarbose has got the better benefits as far as the lowering of the glucose variability, because it usually take care of the postprandial blood sugar level, and that has been documented, that has been demonstrated in different areas, and that's why RSSDI recommends acarbose contributes to the glucose variability reduction by effectively decreasing the postprandial hyperglycemic spike. So you can see that next part, after the glycemic variability, what should be the CV effects? I think the CV effect, MAGE, and the sudden death, that has been taken care by the acarbose. So it also have important action, because you know that macrovascular complications are mostly dependent on the postprandial blood sugar level. If you control the postprandial blood sugar level, I think indirectly or directly that also reduces the CV effects in the form of lowering the cardiovascular events, lowering of the MAGE, lowering of the sudden death. And you can see that if you start giving the acarbose along with the DPP4 inhibitor, the TAR, that is time above range, is drastically going down 8% as compared to 31%. So if you look at this, all this data, I think in your clinical practice you start giving this AGI is one of the important weapon to control the PP blood sugar level in your clinical practice. You can see that 24-hour CGM, only the allogliptin, that means DPP4, it does not take care of the peak. But if you start giving acarbose along with this, that is the green one, you can have a flat effects. That means the glycemic variability goes down. So that is our target. That is our target. Nowadays, it is not that the fasting on PP will be controlled. Nowadays, our target will be lowering the glycemic variability. Throughout the day, we should have less amount of peak, and that's where the acarbose has got the effects. So don't forget the importance of the acarbose, and that's why there are a lot of things with the help of acarbose to reduce the CV risk. I am not going into the details for the time short. I think we are going for the 10-20 minutes. Now you can see that all cause mortality is also death lower down. That means MI all cause mortality is going down with the help of acarbose. And also head-to-head trial with the sulfonylurea that also shows that there is a lower risk of hospitalization due to the ischemic stroke, atherosclerosis and MI. So all that trial, that means head-to-head trial to the allogyptin, that means DPP4 inhibitors, head-to-head trial with the metformin, head-to-head trial with the sulfonylureas, they have shown that it has got a better effects as compared to the other. Next important thing is that the microbiota. I think Dr. Poddar will have enlightened all these things. That is a microbiota. This is a newer concept. I think with the AGI, what happens among the AGI, only the acarbose allows the polysaccharide to reach the large intestine. And that ultimately produces the short chain fatty acids and the H2 gas, improve the health of tissue, and that is the most important aspects, newer aspects as far as the AGI is concerned. So from the starting point, we can see that it is alpha glucosidase inhibitors that ultimately reduces the carbohydrate absorptions in the form of that ultimately have the effects of the postprandial gas sugar level. Then we have got seen that acarbose ultimately stimulated the GLP-1. That is also important because of the newer era. Now we are seeing that it also have effects of the microbiota. So there are 3-4 important aspects as far as the AGI is concerned. It is only not that, because 10 to 15 years back we only think that we are giving the acarbose because just to relieve the carbohydrate absorption, but it is not like that. It has got a better effects, another effects in the form of these 3 areas. So you can see that acarbose has got a more profound influence on the gut ecosystem rather than the DPP4 inhibitors. You can see that changes the baseline, and then we have started the acarbose. You can see the higher abundance of the 5 genera, including the lactobacillus and the dialastar. So these are the important areas where we are giving the acarbose to change the microbiota, and that microbiota will be there for the more than 6 months. So total 108 genera were identified, and nearly 40% were at relatively higher abundance after the treatment of acarbose. This is another aspect of the acarbose or AGI, especially acarbose, because voglibose does not have any this value, because polysaccharides does not process into the lower area because of the voglibose. Only the acarbose has got this ability. So this is another important area to be considered to start the acarbose in our clinical practice. So this is my last slide. So what are the key messages? I think the acarbose improves the IGT, because that's why we are giving this group of drug in the pre-diabetic patient also, improves the type 2 diabetes. In some extent we can start giving the type 1 diabetes when we can have the insulin sparing effects, reduces the postprandial blood sugar level, lowers the post-meal insulin requirements, improve the beta cell function, low risk of hypoglycemia and weight gain. Whenever we are starting any drugs, I think we have to look for the complication in the form of hypoglycemia and weight gain. More effective in the Asian diet versus Western diet, as I've said in my slides, that we are the Asian peoples taking more carbohydrate, and as well as we have the glucose responses to the different to the carbohydrate as compared to the Western countries. So we have to start this group of drug in our clinical practice. Acarbose reduces the glucose variability and reduces the CVD risk factors. The only AGI allows the polysaccharide to enter the lower GI, promote the gut microbiome symbiosis, enhances the GLP receptor secretions. So at the end, I can tell you from this area, we generally forget the importance of AGI in our clinical practice because of the less noise value. We are having more concern regarding the newer insulin, more concern about the DPP4 inhibitors, more concern about the ACL2 inhibitors, more concern about the GLP. GIP or GLP, any other things. But still, I think if you contrast in all these things in our country, I think acarbose or the AGI has got a definite role. If you have got all these things in your clinical practice, you just include the acarbose, see the effects. It is not only the lowering the carbohydrate absorption, it has got all the other parameters like the macrovascular complication reductions, as well as the glucose variability, as well as the gut microbiota. This is very important. I think the take-home message will be, don't forget the importance of AGI in your clinical practice, because all the drugs has got the separate areas. It is not like that you should start, you should omit the importance of the SGLT2 inhibitors, you just omit the importance of DPP-4 inhibitors. You have got SGLT2 inhibitors, but add-on therapy for these AGI has to be included in your clinical practice. Thank you.
Thank you. Excellent deliberation, I would say, on acarbose or AGI. I think we need to stress on two other factors. That's about type 1 diabetes, as you suggested in the last slide, and along with that, in the pre-diabetes stage.
Yes.
Now, the recommendation in pre-diabetes is variable. Presently, still the metformin is the only one which can be given in the pre-diabetes.
Absolutely.
But as far as acarbose is concerned, because you are also aware what you showed in the Dakota trial and all, that it is the prandial sugar which is initially high.
Yes.
Pre-diabetes also what we get is the initial prandial sugar high. So theoretically, it should be the acarbose or AGI which should be of some importance. But none of the recommendations are there. So what's your thought on that, as well as on on type 1 diabetes?
Okay, excellent things. I think AGI is not much popular in the western areas. That's why I think a lot of guidelines which are formulated in the western regions, I think they have not included the AGI as far as the primary prevention is concerned. I think initially what happens, the metformin should be the drug for the primary prevention, pre-diabetic and all these things. Nowadays, they have included any other drugs can be used along with the metformin for the pre-diabetes. It is not that only you should start the metformin, because they have said that according to the patient perspective, whatever the patients you are coming, because there are different type of patients. Some patient is very obese, some patient is less obese, some patient is physically inactive, some patient is physically active. So depending upon the patients, you can choose the second drug or third drug or fourth drug if it is required as far as the primary prevention is concerned. But they have said that if you, there are a lot of studies has been done regarding the acarbose for the pre-diabetic patient, and they have said that if you start the acarbose giving along with the metformin, they have got a tremendous effects, the reversibility. I have shown my one of the slide, that is a 25% reduction in the progression of the diabetes from the pre-diabetic. So in your clinical practice, you can start metformin along with the acarbose without any hesitations. As far as me is concerned, I think there will be the debate, but thing is that if the acarbose is well tolerated, I think it should be started along with the metformin is by first areas. Second question will be the type 1 diabetes. Okay. Type 1 diabetes, I think there are a lot of controversies. I think as it is lowering the carbohydrate absorptions from the gut, I think the load of the absorption from the glucose absorption, if it is reduced, I think the amount of insulin will be required less. Because in case of type 2 diabetes, generally what happens, the insulin levels goes up and up along with the age. So you can prevent the insulin absorptions, that means requirement of insulin as far as the type 1 diabetes is concerned, but it is not the ideal drug. I think ideal drug will be the insulin. Yes.
Sir, as you are aware, most of our diabetic patients suffer from gastroparesis.
Yes.
And AGIs are notorious for their gastric issues.
Yes.
So how about the use of drugs like ripaglinide instead of AGIs for controlling postprandial sugar?
I think this is a very common question for the AGI. Whenever I talk about the AGI, this is the most important things. But the thing is that every drug has got effects over the GI tract. It is not that the AGI only. Because if you start the metformin in 1000 milligram in any patient, I think they will complain that I have a complaint in the stomach and I have a complaint in any areas. So any drug, I think it is better to start in a very low amount of dose. Wait for the few days, few weeks. Then you just up-titrate the dose. I think in cases of AGI also, I think if you start very slowly, like acarbose in 25 milligrams, then goes up, piling up, I think most of the patient will tolerate. If you say 25% patient is not well tolerated, then leave it. but 75% you will try. That's why in our country we start with the highest possible dose, because we want the results in a 4 weeks or 5 weeks time. But that's why we usually miss the bus. I think the patient has got a tremendous that means areas that say that, sir, I will have this drug and I have a complaint, and that's I am not taking all these drugs. So if you start taking the drugs in a very small amount and then goes up, it is also applied for the metformin also. If you start 500 milligram, then goes up, I think metformin is also well tolerated. Same is for the AGI. Well, your question is absolutely right. If it is not well tolerated, then I think we should stop.
Yeah, Kousik, nice presentation. I would very common question, because we are one of the largest metabolic surgery units in the Eastern India. So yeah, so how it works? This is the question, that this AGI, especially acarbose and voglibose, in case of dumping syndrome. So that is because this is the treatment of choice, because a lot of patients, out of at least 10% of the patients, suffer from the dumping syndrome when they underwent either LSG, laparoscopic sleeve gastrectomy, or might be after bypass, which is more common with the MGB or OAGB versus the Roux and gastric bypass. But if the LSG also, we have seen the cases having the dumping syndrome. So because we use either voglibose or acarbose. So your take on this particular aspect?
So in case of dumping syndrome, what happens? I think you have got the most experience of all these things. After studying this, I think this is the most common drug we always use in case of dumping syndrome, because of the slowing of all these things. But the thing is that we generally prefer the acarbose in this area. I think you enlightened, because you have done all these surgeries in your institutions. I think you give more experience rather than me.
No, what you have mentioned, I was going through your presentation, that it causes the increase of the GLP-1 levels in the large gut when it goes down. But simultaneously you have mentioned it only allows to go the polysaccharides, not the monosaccharides or disaccharides. So once as the gut is short, stomach is just bypassed and immediately come. So that's why there is an increased surge of the GLP-1 level and patient got the hypoglycemia. So it prevent the absorption,
That's
or it delayed the gastric emptying. By that it helps what is there, and fantastic results we have seen with it. That is there. Thank you. Thank you. Nice.
But you are using all these things on a regular basis?
Yeah.
Every patient?
No. Patients who are in symptoms of dumping syndrome, in that
that's
situation,
that's
not
my
in
point.
all patients.
Yes,
not
that's
at
my
all,
point.
Not at all.
Yes.
Yeah.
All patients should not get. I think
Only
those patients. Yes.
Only the subset of patients who are in the dumping syndrome, in that situation.
That situation we should. Yes.
Yeah. Thank you.
Thanks.
Thank you. I think we can take one or two questions for the audience here, please.
Regarding postprandial control, we all know the low carbohydrate diet and prandial insulin, and most important, you said AGI. If A1C is very high, should you prefer this AGI or prandial insulin?
No. The important thing is that I think it is individualized. It is not that everybody should
we
get.
all know.
Just 1 minute. You have said that the HbA1c level is very high. I think if the HbA1c level is very high, it is not only the contributing by the PP blood sugar. It also contributes by the fasting blood sugar also. So in that cases, only AGI will be not the sufficient. I have said that. You don't forget the importance of the other oral hypoglycemic drug. It is not that you have started only the AGI, because in that area, either the other oral hypoglycemic drug, if it is not well controlled, then you have to shift to the insulin also. But that is different issue, because if you say that there is a high HbA1c level, that will goes into the different domains, right?